Okay, we're going to start. Well, good morning, everybody. Appreciate your joining us today on the 20th of April. Today we have the pleasure of Seiji Shibata. He's a neurotologist at the University of Southern California School of Medicine in Los Angeles. It happens to be my alma mater medical school as well. And CJ was born in Japan. He went to medical school in Japan. He did a residency in Japan, and then he came over to the United States where he did a postdoctorate in Michigan, then did another residency at University of Iowa, which is probably listed as one of the top 5 ENT programs in the United States. It's probably a little overinflated, but we're going to give him credit for it anyway. And then he did a neuro-otology fellowship also at the University of Iowa with Bruce Gans, who's a well-known neurotologist and chairman of the ENT department in University of Iowa. So I think with that unbelievable introduction, we have a really qualified and well-prepared lecture today. So let's all welcome CJ, and please take over. Thank you very much.
Well, thank you, Richard, for the kind introduction. It's an honor to speak today. My talk will be about otosclerosis. From wherever you are around the world. When I was in Japan, I hardly saw any otosclerosis, but in the United States, we see quite a few. So anyway, we'll get started here. I have no disclosures, unfortunately. So basics, so otosclerosis is a disease of the otic capsule. It was first described in 1893. Pulitzer referred to it as a stapes fixation and dubbed it as otosclerosis. It can cause conductive hearing loss, mixed or pure sensory neural hearing loss. And it kind of depends on the location of the otospongiotic process. You know, when you do cadaver sections and look at the pathology, which Shuknik done in 1985 and presented in a laryngoscope journal, he looked at 123 temporal bones from his clinical otosclerosis patients. 118 had otosclerotic focus starts, which starts really in this area almost all the time, which is anterior to the oval window, and it's called the fistula antifenestrum, which is shown right here. And in the HE stain, you can kind of see the similar kind of area with dense bone, sort of right in front of the oval window. When you look at this on a CT scan, you can appreciate this hypodense demineralized plaque right here, sort of anterior to this is right here. This is the stapes. You can see. Are you guys able to see my pointer?
Yes.
Okay. Yeah. This is yeah. This right here is the stapes. You can see right here, and anterior to it, you can see this hypodense demineralized plaque. Okay. So sometimes this sclerotic pattern can extend beyond the fistula antifenestrum and encapsulate the whole cochlea. And you can see right here, the dense bone engulfs the whole cochlea. And when you look at this radiographically, you can see sort of this iconic double helo sign right here. On both sides, you can see sort of how the pericochlear hypodense double ring is what we call it, but you can kind of see that dense bone surrounding the cochlea. So otosclerosis pathology, histologically, otosclerotic focuses on the histology without clinical symptoms. And then there's clinical otosclerosis, which people show up with conductive hearing loss with otosclerotic stapes, a fixation or blockage of the round window membrane. DeClau studied 236 consecutive temporal bones and had 2.6% had histological otosclerosis. And some people report up to about 6% histological and 0.3% clinical prevalence. So obviously there's more histological otosclerosis compared to clinical otosclerosis. On average, the onset is in the 30s and 40s. People usually present with progressive hearing loss. Most cases, it's bilateral. And female to male ratio is 2:1. And some are diagnosed during pregnancy. Some people talk about the hormones actually affecting otosclerotic progression. Still, that verdict is still out there. We don't really know for sure. It's much more common in white Caucasians. So if you see a Caucasian person in their 30s and 40s and that have bilateral or unilateral or bilateral progressive hearing loss with air bone gap, then most likely it's going to be otosclerosis. It's usually rare in Blacks and Asians. So it's always important to remember that otosclerosis is a genetic disease and it has a autosomal dominant inheritance pattern, has a 25 to 40% penetrance with 40% expression. When you see this in clinic, we talk about the Schwartzy sign, which is the reddish blue hue over the promontory and over window niche areas, and this is secondary to a rich vascular supply from immature bone. You see it in about 10% of your patients, but it's not that common. This is one of the images that I think I got from New England Journal, I think. There was like a case report and they show this Schwartzy sign right here. This is the reflected TM right here. You can see the Malleus, the incus, the IS joint right there, the round windows down here. And then this right here, the red hypervascular area is thought to be the Schwartzy sign. Always important to do a tuning fork exam. When you do a Rene with a 512, usually the bone is higher than the air, and which signals that there's at least a 15 to 20 dB difference in air and sensorineural bone conduction and air conduction. Audiograms are also very important. You can see there's a conductive hearing loss pattern right here. There's usually a type A tympanogram, so the ear looks pretty much normal, but there is, for some reason, there's an AB gap. Patients usually have a good discrim, and then there is the Carhart notch, which is this shows this dip in sensorineural hearing at 2 kilohertz, and we'll get back to that later. And there's no stapedial reflex, which is really, really important to remember when you make this diagnosis, is always to get a stapedial reflex. Patients may have sensorineural hearing loss, so it might be sort of a mixed hearing loss. So acoustic reflex is a very sensitive indicator for otosclerosis, and the stimulus is induced compliance change of the middle ear. In normal conditions, it's a decreased compliance. So, you know, the contraction of the stapedius muscle tilts the anterior stapes away from the oval window, and then it stiffens the ossicles, right? And then increases the impedance, which is measured as the small decreases in the compliance by the ear canal or the probe. And especially in early phases of otosclerosis, you can see an increase in compliance at the onset and towards the termination, and then also sort of a termination of stimulus. And this is also called on and off or phenomenal or biphasic, and it's usually indicative of a early stage otosclerosis. Treatments, I think treatment, it's always important to give your patients options. It's the first option, of course, is doing nothing at all and observing. Second, you can always offer surgery or hearing aids. Sometimes you can offer a BAHA. Once the hearing becomes very progressive and severe, then a cochlear implant might be the next step up. So John Shibb first performed the stapedectomy, vein graft, and prosthesis placement in 1956. Before all of this, Julius Lumpert was doing the famous fenestration approach, which was quite effective, but of course, making the fenestration was more invasive compared to making the stapedectomy. And John showed that the efficiency is it's pretty much equivalent, and also you didn't have to make an endoral incision like you would have to with the fenestration approach. And so given that stapedotomy is now the preferred operation compared to just doing a full stapedectomy. So indications for stapedotomy. So minimum air bone gap is 15 dB, and that kind of brings us back to the tuning fork exam and how important that is. So the tuning fork should be used to confirm the audiometric finding, and bone conduction should be heard louder than the air conduction with a 512 at least. So if you flip the 512, you're a good candidate. If you flip the 256, 512, and 1024, you're an excellent candidate. But you have to flip at least one. I don't know. If you flip one, you're still an okay candidate. But ideally, you would want to at least flip 2 or 3. Patient should always be in good health. Age is not a factor, meaning that even if this develops in people that are in their 70s or 80s, we still tend to offer surgery. And that is because by that time, they've been using their hearing aids for many years, and they've noticed a decrement in their hearing, and the hearing aid is just not effective anymore. And so sometimes if you do the stapedotomy, they notice a really increase in their hearing, and they appreciate you a lot. The poor hearing ear is chosen based upon the patient's statement. Okay. So when not to do a stapedotomy, so if you have balance issues, I think it's always important to ask about whether they have a history of many years of disease, just because I've never actually seen this before, but you can have a dilated saccular membrane that can adhere to the foot plate. So when you make the stapedotomy, it can make things much worse, and it can even cause some deafness. If you have a TM perforation or middle ear infection, you would like to treat that first before you go forward with surgery. And if there really is a very minimal AB gap, and you don't really see the flipping of the fork, then you just kind of back out and just say, well, we'll continue to follow you. The last thing you want to do is make the patient upset because they don't, even if you see audiometric improvement in their hearing, and if they don't appreciate it, then it really is, it doesn't, it defeats the purpose. And you don't really want to operate on only hearing gear. So the stapedotomy procedure, we do it under monitor anesthesia care. We inject the canal. And sometimes I do it with general anesthesia. So either way is fine. We inject the canal with 2% lidocaine, 1 to 20,000 epinephrine, and then we sort of make this canal incision. We raise the tympanomeatal flap, and then mobilize the chorda inferiorly, and then curette the scutum. It's really important to be able to see the whole oval window, posterior crus, and then the facial nerve as you do this, and that's why we tend to take down the scutum. Stapedotomy, always remember to check the ossicular mobility before you do anything. Make sure that the stapes is fixed, and then make sure that your malleus and your incus are not fixed. And you know, there are times when the malleus is fixed, and you might have to do something other than a stapedotomy to close the gap. Once you look at the mobility, you can cut the IS joint, and then at our institute, we use a diode laser at 918 nanometer. You can use a CO2 laser. You can also use a drill. Either one is fine, but we like to use the diode laser. And then we cut down the stapedial tendon, and then we also lyse the posterior cruce before doing a down fracture. So the down fracture, we dislocate the superstructure kind of towards down to the promontory, and this allows us to get a full view of the foot plate. Once we get a full view of the foot plate, we make a small rosette here. We make holes using the laser. So it's about 0.7 millimeters in size. And then we can also use a oval window rasp to widen the hole, which is, the tip of it is 0.7 millimeters. So that's sort of an important number to remember when you make the fenestra. The reason is because most pistons, the diameter, the end that goes into the vestibule is usually 0.7 millimeters. And so you kind of want to make it the same size so that it can accommodate the piston. You can place the piston on the lenticular process of the incus, and then you can either use a crimper, or you can use a laser heat activated crimping system like a smart piston or a Nitinol polytef to crimp the prosthesis. I like to use the smart piston, and you can heat activate it at 45 degrees, which crimps the end of it, and then it kind of is very stiff, and then it catches the incus so that it mobilizes as a unit. Once we're done with that, we place the tympanomeatal flap, and then this we check for soft whispered voice, and you can only do this when it's under monitor anesthesia care. It's hard to do this when you are doing general anesthesia. So when I was going for interviews for my neurotology fellowship, I spoke with Daryl Brackman about stapedotomies, because he was doing a stapedotomy case during our interview. And he mentioned that you should not whisper at the end of the voice, at the end of the case, because it doesn't really change what you're going to do, is his argument. But I always thought that, you're supposed to talk inside the ear to confirm that you did a good job, and that was like the highlight of the case. And that made me think, well, then why don't you just do a general anesthesia and not do anything? But I think the reason why people like to do monitor anesthesia care sometimes is because you can catch vestibular symptoms immediately after surgery. If, for example, if the prosthesis was placed too deep, that's the benefit of doing it under monitor anesthesia care and not being able to whisper into the patient's ear after surgery. So it's always really important to look at the mobilization of the malleus and the incus before you cut the IS joint, because you can have a malleus fixation, and it doesn't really have a like an audiogram feature. It doesn't really show like tendon reflex absency, like the stapes fixation. It happens in 1 to 200 patients, and it's always noted at the time of the surgery. And the Malleus head fixed to, and this shows sort of the Malleus head fixed to the anterior epitendon right here where the arrow is. So if you have a Malleus fixation, what can you do? Well, you can remove the incus and then clip the Malleus head and then do a stapedotomy. And then what you can do is place a Malleus vestibular opexy prosthesis, which kind of look like this. And that's the alternative if you have a fixed Malleus. And for example, a fixed, if you have both, like if you have a fixed stapes and a fixed Malleus, then this is what you would do. Intraoperatively, you can also find things that might make you want to not do surgery. For example, if you have an overhanging facial nerve, the facial nerve can be dehiscent over the oval window, and you want to try to be conservative with these and not be very aggressive and try to mobilize the nerve. If you can do it if you're really experienced, and try to make a fenestration. But sometimes the heat can actually cause facial nerve paresis, paralysis. So I probably wouldn't be too, the heat of the laser can cause facial paresis paralysis. So I wouldn't be too overzealous about doing a stapedotomy in a person with an overhanging facial nerve. And y'all should always remember that the alternative, of course, is a hearing aid. Obliterative otosclerosis, if you have a really thickened foot plate, incus foot plate, distant short, and then, what we can do, we can laser it, and then you can use a skeeter drill to make a fenestration into the foot plate. So there are complications, of course, with the stapedotomy procedure. You can have hearing loss, vertigo, facial nerve paralysis, tympanic membrane perforation. Chorda injury is also pretty common, but usually transient, and then long-term failure. Revision stapedotomy, displaced prosthesis is the most common reason for revision. As you can see here, about 41% of the time of primary causes of failure. You have to remember that with revision stapedotomy, a lower rate of ABG closure than primary stapes, and then 55% closure of the ABG to within less than 10 dB, and then average 74% closure to less than 20 dB. And then there's always a higher rate of sensory neural hearing loss that kind of ranges around 5%. So before we go into surgery, we always need to be cognizant about other causes of AB gap that we need to diagnose. One of them is superior canal dehiscence, which has conductive hyperacusis, and then because of the third window phenomenon, and people often have autophony, and sometimes they don't. And with superior canal dehiscence, you can kind of see that there's typically a lower frequency AB gap and bone conduction of less than 0 dB. If you compare superior canal dehiscence to otosclerosis, these are some of the differences. You can have conductive low frequency, and then bone, you can have conductive hyperacusis, and then acoustic reflex. This is most important. Acoustic reflex is present in superior semicircular canal dehiscence, and BEMP is decreased threshold with semicircular canal dehiscence, but sometimes BEMP is not like available at all facilities, but usually acoustic reflex is available. So, if you see a present acoustic reflex in ear that has a B gap, you always want to try to get a CT scan. Yeah, otosclerosis, you can have conductive hearing loss in all frequencies, and then sometimes you can see the Carhart's notch, and then acoustic reflex is absent, and then usually you wouldn't see a vamp and no changes in the thresholds. So remember, acoustic reflex testing can help differential otosclerosis from superior semicircular canal dehiscence. So if you have a really far advanced otosclerosis, which is the criteria, the Sheehy criteria is air conduction is more than 85 dB and bone conduction is beyond detection. Usually they have a positive family history, meaning that their father had it, their mother had it, and the onset of progressive hearing loss usually starts before the age of 30. And then prior audiogram showing air bone gap, and then there's really no other causes of hearing loss. I just want to show you right here the section of the far advanced otosclerosis. You can see that dense bone kind of engulfing the cochlea, but I think the point what I want to make is you can see that the cochlear lumen is actually still open. So you can see that there's no dense bone inside the cochlea. So the cochlear partitions of the scala tympani are still open. And you can see the spiral ganglion cells there appear to be still intact. So for far advanced otosclerosis, the treatment, of course, would be a cochlear implantation, and that's still possible because the cochlear partitions are still open with even far advanced otosclerosis. It's just the bone, the demineralized bone that's engulfing the cochlea, and inside the cochlea, the lumen is usually normal. But for I think we placed a contoured 632 cochlear implant in far advanced otosclerosis, but we usually have a backup for a straight just in case there might be some kind of bottleneck or area that's narrow that won't allow us to place the contoured cochlear implant. But most cases that I've seen, the cochlear implant goes in quite easily. For far advanced otosclerosis, this is a retrospective study. They looked at 11 patients, 6 stapes and 5 CIs. There was variable hearing outcomes with the stapes, but all CI patients had a satisfactory hearing, and that goes to tell you that the spiral ganglion cells are usually intact within these patients. So with far advanced otosclerosis, the conclusion is you can go ahead and try to attempt to face stapes first, and then you can reserve a CI for those who fail. So complications for far advanced otosclerosis, you can have some facial nerve stimulation, which seems to occur at a higher rate compared to normal cochlear implants. The labyrinthine segment of the facial nerve stimulated by the middle electrode, and for this you can basically just deactivate the electrodes that are causing the stimulus and just reprogram the cochlear implant. So a lot of times this is not that big of an issue. So patients that also have a really bad otosclerosis are patients with Osteogenesis Imperfecta. They have fragile bones, blue sclera, hearing loss, and usually they have mixed hearing. Conductive component is due to stapes fixation. So these patients you can operate on and they can improve their hearing. 60–80% get AB gap closure of less than 10 dB with stapedotomy, but you have to be really careful with these patients because their bone is so brittle. Yeah, we did I did one with Dr. Gantz, which was pretty interesting, but in the end we were able to get the prosthesis on, and he actually improved his hearing. So in summary, otosclerosis is common in the Caucasian. Fistula antifenestrum is effective first. Stapedotomy with the smart piston is over 90% successful. When you do a revision stapes, it's often due to displaced prosthesis and is less successful than the primary stapes. And so if you have minimal closure of your AB gap, or you had a successful AB gap closure and you see hearing loss again, then you probably would want to get like a CT scan to confirm the displacement of the prosthesis. Another point, acoustic reflex is absent in otosclerosis and present in superior semicircular canal dehiscence. It's always important to differentiate these two. I know multiple people that have been burned by this by not getting a CT scan prior to doing their stapedotomy. If you do a stapedotomy in somebody with superior semicircular canal dehiscence, even if they did not have autophony prior to surgery, they can develop autophony and they can develop bad symptoms after that, and it will make you look very bad if you hadn't taken a CT scan and hadn't taken the time to look at the CT. So yeah, I always get a CT scan for my otosclerosis patients. It used to be that we would just take him to the OR, and Bruce Gantz would always take him to the OR without getting a CT, but I'm pretty sure he's changed his practice after being burned by a couple of these in the past. Stapedotomy should be offered for far advanced otosclerosis to improve the use of hearing aids, but results are sort of variable, so you probably want to notify your patients about the variable results, and then also offer a cochlear implant if things fail. It's always important to talk about facial nerve stimulation in these patients with otosclerosis or far advanced otosclerosis, and a lot of times with the help of your audiologist, you'll be able to reprogram the cochlear implant. Many genes have been implicated in this complex genetic disorder, so we're not going to go into that. So I would just like to go over a few cases, and then we'll talk about epidemiology, symptoms, audiology, some quiz questions, treatments, results, complication, and kind of diagnoses, pathophysiologies, and genetics. So I'm just going to read out these questions, and I'll just answer them myself. So case number 1, JB, is a 55-year-old female with left hearing loss, has gradual hearing loss on the left side since 2001, age of 46, has no vertigo, no otorrhea, 2 prior middle ear explorations. Local doctor found ossicles to be mobile and performed lysis of adhesions. Past medical history, social history, family history, non-significant. On physical exam, facial nerve wasn't normal. Ear exam is pretty much normal. The Weber goes to the patient's left, and the patient is able to flip 2 forks, which in this case, if they have, they flip 256, it's indicative of 15 to 30 dB conductive hearing loss. 512 would be 30 to 45 dB. 1024 would be 45 to 6 dB, which would make them a surgical candidate. So you can see this patient's audiogram has a left conductive hearing loss, and you can also see a Carhart's notch right there. And at this point, you can make a diagnosis of left otosclerosis. But yeah, I would probably get a CT scan as well in these patients. But quiz number 1, where is the most common location of otosclerosis of the oda capsule? It's fistula antefenestrum, cochlea, stapes foot plate, fistula postfenestrum. And the answer would be, of course, fistula antefenestrum. Just kind of an overview of the audiogram features. With the Carhart's notch, it's not an actual dip in the sensory neural hearing loss, as you can see right here. It's an artificial elevation of bone conduction threshold at 2 kilohertz. So it appears because of the inertial contribution of the normal ossicle chain to bone conduction. And the interesting thing is you can resolve it with stapedotomy. Case number 1, and so we did a middle ear exploration. Stapes fracture found to be fractured, and the stapes foot plate was fixed. And so we did a stapedotomy and placed a 4.5 millimeter piston, and we saw a post-op closure of the AB gap, as you can see right here. So what kind of materials should we use? So we like to use a smart piston just because it's malleable and it's easier to use compared to the titanium prostheses. And you can see there's a study that was done, a prospective study, which consisted of 90 patients with the smart piston compared to the titanium prosthesis, and there was a 90% closure of the AB gap to less than 10 dB in the nitinol patients. So it's pretty much equivalent. And then long-term closure of ABG to less than 10 dB, then there was a less variability compared to the conventional piston when you look at pre-op, post-op. Seems like, and the nitinol piston seemed to perform better. And from my institute at Iowa, we saw similar results with the smart piston. Dr. Brown, who's the director at UNC, and Dr. Gantz, when he was a resident at the time, they looked at pre-op ABG of 37 dB and then post-op ABG of 8 dB in patients that got the smart piston. So the smart piston is very effective. So quiz number 3, what is the most common reason for conductive hearing loss after stapedotomy? Incus necrosis, displaced prosthesis, bony closure, adhesions. And yes, the answer would be a displaced prosthesis. Next quiz. So 36-year-old patient with 15 dB conductive hearing loss, type AD tympanogram, normal acoustic reflex and normal otoscopic exam, the most likely diagnosis in this case. So the kicker right here is sort of the normal acoustic reflex, right? If you see that, then it's most likely going to be an undetected labyrinthine dehiscence. So case number 2, this is a 45-year-old male with decreased hearing loss in the left. He can still use the phone on the left ear. So patients that can still use the phone are, I always, this is kind of unrelated to stapedotomy or stapes, but for patients, when I screen patients for cochlear implant, I always ask whether they're able to use the phone, which ear they can use the phone on. If they aren't able to use the phone or have a conversation over the phone, that gives me an idea that they might be a candidate for a cochlear implant. Okay, so so this patient can still use the phone on the left side, which is great. And then he noticed autophony, which improved with cotton in the ear canal. He would also have disequilibrium with quick turns. Past medical history of sarcoidosis, which I'm not sure whether that makes a difference or not. But he has a normal tympanic membrane, and then he had a negative fistula test. I don't know if you guys use pneumatic otoscopy exam, but for identifying superior semicircular canal dehiscence, it's very effective. And so if you don't have it in your clinic, I would recommend getting it. And also it would give you an idea whether there's fluid behind in the middle ear. And so this patient had a low frequency conductive hearing loss, as you can see here. And then he had normal acoustic reflex. And then we got a transfer cut on the IAC that shows superior canal dehiscence in the left ear. So for this patient, if we see this, and if the patient is really bothered by their autophony and their disequilibrium, they're very symptomatic, we usually offer surgery. And our preferred method is doing a middle cranial fossa approach and then identifying the arcuate eminence and kind of looking at the blue line. A lot of times when you raise the dura, you can already see that the superior canal is open, and so you want to try to irrigate it as much as possible. The last thing you want to do is kind of suck on top of the superior canal dehiscence, because sucking out that perilymph will make the patient go deaf. And so kind of the irrigation, kind of keeping the suction away from where the dehiscence at is really important. We usually resurface the superior canal dehiscence and place some fascia, bone chips, and then a lot of times I put bone cement on the surface to reinforce the skull base. And these patients, a lot of times they have improved hearing and autophony. And a lot of times the autophony, when it goes away, it's pretty quick. Immediately after surgery, they might be dizzy, but their autophony usually goes away pretty quickly, and they're very appreciative of that. The closure of the AB air bone gap can be variable, but at least the ones that I've seen so far, it seems to be pretty effective. So quiz number 5, patient with air conduction threshold greater than 85 dB, hearing level and bone conduction thresholds that exceed the limits of the audiometer. This patient is most likely have far advanced otosclerosis. If there is a family history of hearing loss, there is a perception of pulsatile tinnitus. Previous audiogram demonstrates an air bone gap, and the stapedial reflex are absent. Yeah, I don't think I mentioned this, but so patients with pulsatile tinnitus can also be, pulsatile tinnitus can be initial symptom of otosclerosis. I've seen this multiple times where they have pulsatile tinnitus in one ear, and when you do the workup, it turns out they have otosclerosis. And so in this case, the answer is a previous audiogram that demonstrates an air bone gap. And then for case number 3, so 73-year-old female with hearing loss for many years, had successful stapes on the right side in 1997. Unable to use the phone now and has no family history of otosclerosis. Some benefit of the right hearing aid and no benefit of the left hearing aid. So this is a patient that's kind of old and has some hearing loss. But when you do an audiogram, you can see that there is an AB gap, and then patient is unable to hear the forks. Even with these patients that are relatively old, we opt to do surgery sometimes if it's clear that they have otosclerosis, and In this patient, we got a CT scan which showed far advanced otosclerosis. So in these cases, you want to start out with a stapedotomy, and if that fails, then you can always switch over to a cochlear implant. So this patient got a stapes surgery and had, you can see the left and right, there's really no improvement. So in this case, because there's no improvement in hearing, we sent the patient for a CI eval. This is case number 4. It's a VA patient that we saw, was wearing hearing aids since the 50s, had minimal benefits now, had the stapes in the past, and hadn't been able to use a phone for 7 years. On exam, the TM's intact, whoever goes to the left. CT shows a prosthesis, and then the right side, there's a sclerotic otic capsule bilaterally. And on audiogram, has severe mixed hearing loss with conductive hearing loss, 9% aided hint score with left on the left side, and the stapes is on the left. And when we do stapes in this year, we saw a gain, and then 16% were discriminated, improved use of hearing on the left. And so this case was a successful case of using, doing a stapedotomy in an older patient with far advanced otosclerosis. So this might be a couple more slides, but I don't know how we're doing with time. But this one is an 18-year-old female with hearing loss for many, many years, has a blue sclera, history of bone fractures. Of course, if you see that, it's a diagnosis of Osteogenesis Imperfecta, has profound mixed hearing loss in the right ear. If you get a CT, you can see the demineralization of the cochlea, and diagnosis, of course, would be a far advanced otosclerosis. In this patient, we did a right stapes, and we were able to see improvement in the right ear. So Richard, how are we doing on time?
We got about, it's 10 minutes to 11. If you want to finish this and we can hit some questions, I have some questions. I'm sure some of the other people do too.
Okay. I'll just do this one last question right here. So stapedotomy is contraindicated in which patients? Patients unable to receive general anesthesia, patients with recent upper respiratory infection, patients who are non-hearing in the opposite ear, and patients who are audiometrically normal in their other ear. And this is sort of a multi-answer, which if you have upper respiratory infection, you want to treat them so they get better before you do surgery. And if they have a non-hearing ear in the opposite ear, then certainly you don't want to do a stapedotomy given the chance of losing all of your hearing with the surgery. So yeah, so that's sort of, should I stop there?
Go for one more.
Okay, one more question. So number 2, patient is referred to you for a stapedotomy. She has a 30 dB AB gap in the right ear and severe profound sensorineural hearing loss in the left ear. What do? You can do a stapedectomy in the right ear, stapedotomy in the right ear, stapedectomy in the left ear, or aid the right ear, or observe. Yeah, so do no harm, which is aid the right ear. Okay.
All right. Okay. Seiji.
Yes.
Couple things here. I think it would be important if you could explain to everybody what the cause for when you've got a patient with a mixed hearing loss and they've got only otosclerosis. Explain to everybody what causes the sensorineural component when you have cochlear otosclerosis.
So, I mean, some of it can be mixed hearing loss with the sensory neural component due to age. And then, of course, there's, because of the mineralization around the cochlea, there's less of a bone conduction, which leads to the sensory neural component of the hearing loss. And so once the mineralization goes beyond the fistula antifenestrum, it's not just a conduction problem. It becomes more of sort of the resonation of the bone inside the inner ear.
And what about like, I believe I read that at least some people think that it's due to the active enzymes from the otosclerotic focus that gets in the scale of vestibule.
Yeah, yeah, some of that, I think, you know, yeah, I think some of that is true. I just don't really know if that's totally the case. It seems like if you see, I would see more patients that have that kind of like a sudden onset of sensory neural hearing loss with otosclerosis, if that were sort of the more prevalent cause of the sensory neural hearing loss component, but certainly that is a portion of, that does explain some of it.
I guess what we need to do is take perilymph samples from people who have significant cochlear otosclerosis, while they're alive to see if there's any kind of higher protein concentration. We'll have to see.
Yeah, I mean, the people are doing, like Heinrich Stecker is doing a lot of perilymph biopsy for patients that are receiving cochlear implants. So I think, I'm sure he has a cohort of patients with otosclerosis, far advanced otosclerosis, which he's doing perilymph studies on, I think. But I'm not really aware of what has come out of that so far.
The other thing is, with Meniere's disease, I've read that people will do stapes surgery if somebody's had no symptoms for Meniere's for a year. I kind of think that
Right.
I think that's blown out of reality because there's no way of predicting when Meniere syndrome will manifest itself. So you put a piston in, your saccule goes to the piston, the distal piston, and the patient gets dizzy. You've done nothing for anybody.
Yeah, exactly. And I think, this is sort of a functional surgery. And so you kind of want to talk the patient through all the risks, and, you certainly don't want to make them worse. And so, if they have a history of Meniere's disease, I would be very cautious about taking them to the OR.
Mm-hmm. And then the other thing is, I do all my stapes. I don't know. I can't remember when I did a stapes under general. Like Giovanni's kind of left, but Giovanni's from Northern Italy. He's kind of like the guru of Italian otology. I think he puts Mario Sana to shame. But the reality of this is that when you do stapes surgery under local, it's like God's gift to otology because you monitor vestibular and cochlear function with the patient. And as you said, I don't care if they can hear my whisper. All I want to know is, can they hear sound? If they can hear sound, I know one thing: they don't have a dead ear at that phase of the surgery. Okay, that's all I care about. And like I say, you can monitor vestibular function, which is like, to me, like it is the gift. And then I'll just mention one other thing. This the mapping of the human genome, where they're able to now sickle cell disease, for example, they've got a couple of patients who they've done genetic injections of, I don't know what the hell they're injecting, but it's maybe the sequence that gets repaired in the sickle cell patient. And there's some patients now that they've been symptom free from sickle cell in excess of a year, well in excess of a year. So the question is, even though otosclerosis is a cosmetic deformity, It's a cosmetic disease for us. It's not a life-threatening disease. People can live with all kinds of alternatives. But, you know, we can find the gene for this, and maybe we can correct all people who have autosomal dominant, otosclerosis, and, we won't have to do stapes surgery in the future.
Yeah, that would be very sad.
I'm reading this book right now called the Code Breaker.
Yeah.
It's about the researchers at Berkeley who did the CRISPR
All
cut.
right.
Anyway.
Yeah.
Okay.
Yeah. I think I think for hearing at least, sort of those, I think like gene therapy studies, and a lot of those are, done in animal models. Even in animal models, once they're like have mature hearing, it's very hard to reverse the course of the hearing loss. And so, you have to hit them at the right time, basically when they don't have any symptoms. And so it makes it very difficult, if you have a genetic inheritance that most likely is going to cause you hearing loss in the future, but you don't currently have hearing loss.
Okay.
But your best shot of preventing it is to doing something right now. It would be really hard to convince people, I would think. Yeah.
Does anybody else have questions? Mega from Ethiopia, Aziz from Somaliland, Asuk. Anybody got any questions for Seiji? He'll answer them for you.
Hi, I have a question.
This is Artem. Artem's from Chernobyl, Ukraine. He speaks
Artem.
He speaks fluent English, and his father's a otologist. So Artem, please
Oh,
ask.
great.
Thanks for
Hey,
joining.
Artem. How are you?
Thank you, fine. Thank you for a great lecture. My
Yeah.
question is, do you how do you see endoscopic otosclerosis, endoscopic stapes surgery?
Oh, endoscopic stapes surgery?
Yeah.
Yeah, I think it's great. I think it's great. It's just that I think there is a learning curve, because you don't really get that depth perception when you do the endoscopic approach. And so you kind of really want to get really used to the endoscope before you start, doing the stapedotomy. I would try to be really careful about doing that. I don't do that right now. I know a few of my colleagues that do that, but I think in the future, once I get more used to using the endoscope, I might venture out and do that as well. I think the view that you can get with the endoscope is so nice, and you can get a really close-up view that I think that really is an advantage compared to the microscope. But I think you can only use one hand with the current technology that we have. So, and if it bleeds, then you're kind of screwed. So, I try to use both if I can.
Yeah,
Thank you.
I'm a proponent of the microscope for stapes surgery for two reasons. First, I think of all the surgeries we do, two hands is the ultimate experience with stapes surgery. Second of all is, unless you've got a lot of experience doing stapes under endoscopic vision, you're going to take a long time to do it. And I agree, the anatomy is really beautiful when you stick your tip of the endoscope near the oval window. You can see things you can't see with the microscope. But this isn't about the beauty of videography. This is about getting surgery done, getting it done effectively, reducing anesthesia time for the patient, and giving them a good result. And I think really the best way to do that is unless you're like super experienced with the endoscope, is to use a microscope. It's just my opinion.
Yeah, no, I agree. I think that being able to use both hands is really important with these procedures, and when you're stuck with one hand, it's very hard to do.
Mm-hmm. Any other questions? Oscar, you got a question from Ivano-Frankivsk, Ukraine?
Yes, hello. Thank you. Very nice presentation. I actually saw one patient with otosclerosis this morning. My question, actually two questions. The first one, just the curiosity, because you mentioned that in Japan it's quite a rare disease. So I was just
there's a report that suggests that it's not as rare as we think it is, but it's definitely less common in Asians compared to Caucasians.
Okay. And the next question, you mentioned that you use the old laser for removing the stapes superstructures. It's relatively cheap, and we have this laser in some private clinics in Ukraine. And as I understand, the length of this wave is important. Is it possible to use a different length of this laser?
Some people use a CO2 laser, but I would be very careful with using the CO2 laser because it sort of emits a gas. So when you're making the fenestration, I've heard of people like misused it and like blowing away all of the perilymph with the gas. So I would be, you know, if you once you're used to using the CO2 laser, I'm sure you'd be fine with it. But that's one thing that I've heard from various people, that sometimes the CO2 laser, you can the emitting gas is kind of a problem.
Okay, and I also read some articles so they actually describe when this wave like hits back and can hit the facial nerve using the laser.
Right. Yeah, that can happen sometimes.
Any type
but again, it's pretty rare. Yeah, when you do this, you really want to take down that scutum and be able to see all the structures and make sure that your facial nerve is not close. So yeah.
So the key, Oscar, is reduce complication risk by reducing complications, which means don't use the laser.
Yeah, what do you like to use, Richard?
I use a skeeter drill.
Yeah.
Matter of fact,
so
I use a bin air drill. It's like it's called the Otostapes. It's like a skeeter. I use it to drill posterior crura. I use it to drill the fenestration. I put my piston in before I remove the anterior crura. Okay?
Oh.
And before I separate the joint. Then I separate the joint, take the anterior crura down. Why? Because I don't want to float the foot plate.
Yeah.
Okay.
That's what Dr. Gans liked to do. He didn't fracture it before putting it in. So
you know, but one of the things you said is that, you know, and it's really critical, is people need to check for mobility of the ossicular chain, because, you know, we get in there, we're here to do stapes surgery. We kind of forget we need to confirm the diagnosis. Other than audiometric, okay, and history, we need to confirm it anatomically. Okay.
Yep. Yeah.
You know,
for
and
sure.
if you've got any doubt, don't do it. Okay.
Yeah. Don't do it. One other thing I would add is I would get a CT scan for all my otosclerosis patients. I don't know about you, but I've seen a couple patients where I was like, whoa, you have, you know, otosclerosis. I'm going to do a stapes in you and you're going to be so happy. But yeah, well, you know, maybe I'll get a CT scan and see what you have. Boom. They have, you know, superior semicircular canal dehiscence, and they're like, no, we don't want to do surgery. So
yeah, I mean, there might be about 5 patients out of about the 500 I've done for stapes surgery that retrospectively I've gotten a CT scan on. But
yeah,
in terms of cost analysis, if I had done 500 CT scans, you know, versus having retrospectively do only 5, I think there's a big cost differential. So
yeah. So.
And can I also
any other questions?
Yeah, just one more question. When Richard visited in Ivano, I remember 2 patients. Then we usually do not do the CT scan because it's relatively expensive. So the stapes was mobile, and the surgery was not done. And what if we do the CT scan and there is no superior semicircular canal dehiscence? What's the possible diagnosis in this case?
I mean, is like the malleus fixated, or is there like fibrosis, or nothing like that?
Okay, so probably something with the vesicular chain.
I would think so, but I guess the first question would be, did they flip their forks?
I believe that Richard will not do a surgery if the patient
Yeah,
flip the
if they
forks.
don't flip their forks. Yeah, yeah. Yeah, you know, I've had some people that in the exact same situation where we went in and everything is mobile, and you know, we couldn't find anything that was causing conductive hearing loss, so we aborted. Yeah, I don't, you know, other than getting a CT scan and making sure that there's nothing along the like a third window. I don't know, what else could there be?
A session with Sigmund Freud. Okay.
Yeah. Yeah. Yeah.
Thank you.
Yeah.
Okay.
Those are tough ones.
Any other questions? Well, listen, I appreciate Seiji, your lecture. I've got there's been numerous comments on here of your great lecture as well. If anybody has any questions, please put them on the forum. This lecture is going to be recorded. It will be on the YouTube website for Global ENT. And I hope everybody learned something. There's, no matter how often you hear a lecture that you've heard before, there's always something new to learn. And thank you very much from Los Angeles, USC School of Medicine, and Seiji Shibata. Thank you.
Yep. Thank you.